Hola, bienvenidos a un episodio más de Sobre la Mesa en el entorno de este maravilloso congreso de CITIC 2025 en la Ciudad de México. Soy el doctor Xavier Escudero, cardiólogo clínico y intervencionista en la Ciudad de México. Y tenemos ahora la oportunidad de contar con dos grandes autoridades de un tema muy importante que es la enfermedad multivascular y cómo la abordamos. Y para ello contamos con, decía yo, dos grandes profesores que han estado involucrados y son, diría yo, autoridades específicamente en este tema. Tenemos la oportunidad de tener al doctor Robert Welch del Hospital Universitario de Alberta en Canadá y al doctor Ripal Bangalore, quien es el jefe del laboratorio de investigación y de pacientes de alto riesgo en el Hospital Bellevue de Nueva York, ambos con múltiples publicaciones en este aspecto. So, welcome to On the Table in CITIC, and thank you for your time in this very important and particular aspect, which is multivascular disease. 60, let's say 70% of the patients that arrive to the cath lab has multivascular disease, and what are we going to do with them? How should we treat it? And we have mainly two scenarios, and one is the acute coronary syndrome. So let's start with you, Robert. And welcome. And what do you do in terms of the multivascular disease patient that arrives with an acute coronary syndrome?
Yeah, I think some of the great news about the patients with multi-vessel disease with an ACS, especially with STEMI, is we actually have a lot of high-quality data which can really guide us. So we know from the COMPLETE study and others, it's not the only one, it's the largest, but there's other really high-quality studies that treating the non-culprit lesion and trying to achieve complete revascularization improves outcomes, and in meta-analysis it decreases hard endpoints, including cardiovascular death. So it's one of the rare situations with multivessel disease where our signal is so strong and quite clear. So then the debate is the who and who not, and to me the how and the when. So the who not from randomized data, again, we're very fortunate in this area, seems to be cardiogenic shock, at least for immediate multi-vessel PCI. But if they survive, staging is probably appropriate. The other who not, to me, is someone with renal insufficiency and a long procedure or patient team fatigue. We've got to take those types of very practical things into context. And then the timing, I think, even though if you look at the combined endpoint, death, MI, urgent vessel revascularization, looks very much in favor of an immediate strategy. I think if you take the complexity of diagnosing an MI and a STEMI into account, and that urgent revasc, if you stage in a reasonable time frame, probably is negated, that we've got our choice. So I would say that there's a lot of choice in the timing. The how, in terms of what to do, a paper that one of our colleagues and friends led, it's a registry analysis, so we have to be cautious, but we tracked a continuous variable of completeness of revasc to hard outcomes and achieving a jeopardy score of less than 10%, which would equate to a distal territory lesion or a branch lesion. If you can achieve complete revascularization level, that seems to be where it flattens out and the benefit is achieved. So that's the other part of the how. And then the functional assessment appears to be neutral. You can do an angiographic or a functional assessment. And the big what to me that we don't know, and we talked about this briefly earlier, is the impact of imaging. Should we be doing routine imaging? Will it guide and change which lesions we treat? You know, we know TICFA is related to events if we selected the right lesions. But until that work is done, I would still think that it's mostly to support optimizing your procedure, not necessarily choosing your lesions to treat. So how's that for a whirlwind summary?
That's a perfect resume. So if the situation is ideal, the patient is stable in acute coronary syndrome, you should go and do whatever you have to do in terms of treating all the lesions if you can in the same timing. You have the possibility of doing that afterwards, and ideally during the hospitalization, or then staged it if the situation is that. Well, that was perfect, and that was very guiding. But let's move to chronic vascular disease. And what do you, so what do you do in a chronic coronary syndrome patient?
Yeah, so, as was pointed out, we have randomized trials from ACS, which clearly show there is a benefit of complete revascularization. I can point out that in the stable coronary disease, we don't truly have randomized trial data, but all of the observational studies seems to point exactly in the same direction. If you completely revascularize with the best modality in a stable coronary disease patients, your outcomes are better, including, and of course, there is a lot of confounding in observational studies, including a reduction in cardiovascular death, MI, etc. We need randomized trial. But what we showed in the ischemia trial, where we are comparing invasive versus conservative, even in that trial, completeness of revascularization was actually beneficial. There was better reduction in cardiovascular events, better improvement in symptoms when you compare with medical therapy alone. So to me, I use the totality of data. ACS is the driver saying completeness of revascularization is better. So if I have a patient with multivessel disease, the first question I ask is, can I completely revascularize with PCI? If the answer is no, I'd rather send them for CABG. So I choose a modality where we can best completely revascularize our patient. And of course, then there are, exactly to Rob's point, other patients where completeness of revascularization may not make a difference. If you're frail, elderly, if you have small diffuse disease that there is no way you can completely revascularize, these are patients where reasonably complete revascularization is the way to go. You leave the rest of it to medical therapy alone.
And in terms of imaging, how do you do that in your center?
I am a big proponent of intravascular imaging. What we did also is we did an analysis of whether it should be angiographic guided, whether it should be functional guided or intravascular image guided based on meta-analysis of randomized trials. And we looked at separately for ACS and non-ACS trials. What we showed was the best strategy was intravascular imaging. The second best strategy was physiology-driven strategy. And the worst was actually angiographic-driven strategy. I do agree that we need more data. So in the stable world, I tend to use both physiology and intravascular imaging. Physiology more to diagnose. If I have an intermediate lesion, should I stent versus not? I use physiology. And intravascular imaging more for optimization of PCI.
If I can interject, the ischemia analysis you talk about is one that I think most people aren't aware of, or at least it doesn't get discussed enough. And I've actually used that in the debate against a surgeon about completeness of revasc with surgery versus PCI, because that analysis actually showed that you got more complete revascularization with PCI than with surgery. But obviously it's anatomical selection and hard to take away the bias.
Right.
But the other part of that is it's very impressive, and it is an overall neutral trial of an invasive versus a conservative strategy. But if you are going to go the invasive path, I think it again proves that complete revasc has got to be your goal, with logical caveats around CTO, small anatomy, small branches, or unsafe lesions.
Well, that has been very enlightening. We know now how to do it better. And thank you very much for your clear concepts to help us. So thank you very much. Welcome to Mexico. Hope to see you every year here in this event. And thank you very much. Muchas gracias. Creo que hemos aprendido de cómo manejar mejor la enfermedad multivascular. Quedamos atentos para el siguiente episodio de Sobre la Mesa. Muchas gracias.